Okay, it is now 11 a.m. Central Time, and we are going to get started. So, thank you for joining the sixth virtual resident education lecture series today. Today's topic is BPPV Mechanisms, Myths, and Management. Today, we have Dr. Daniel Weber, Adult Epilepsy Division Director at St. Louis University School of Medicine, joining us as our Q&A moderator. Dr. Weber started doing a virtual lecture series at the beginning of the pandemic on his own and now has connected with the AAN to continue this resource for residents. I'm also pleased to introduce our speaker for today, Dr. Kamala Saha. Dr. Saha is an assistant professor of neurology at Barrow Neurological Institute in Phoenix, Arizona, in the Department of Otoneurology and Vestibular Neurology. She is director of the Neurology Clerkship at the University of Arizona College of Medicine, Phoenix. She is also a clinical assistant professor of neurology at University of Arizona College of Medicine, Phoenix, and assistant professor of neurology at Creighton University School of Medicine. Dr. Saha, I will turn it over to you.
Great, thank you so much. I want to just start off by saying thank you, Allison, for setting all of this up. It's such a wonderful opportunity, and thank you to the AAN for inviting me to participate in this virtual resident education series today. So the topic today is neuro-otology, and I thought that it would be fun to speak to you about BPPV. This is something that we all kind of know a little bit about, at least, and learn about, and it's just so important to be able to treat to help our patients. So I want to spend a little bit of time discussing that with you guys today. So I'm coming to you live from Phoenix, Arizona at Barrow Neurological Institute, and this is where I did my own neuro-otology fellowship and now work in the Division of Neuro-otology here. So let's get started. We're going to be talking about the mechanisms of BPPV, the myths, and then a little bit about the management. And in order to really understand how this occurs and how best to treat it, I think it's best to actually delve a little bit into the anatomic background first. So just broadly speaking, the inner ear's function is, of course, to detect sound, and it's also to help maintain our balance system. And of course, the parts that we need for this would be the cochlea, that snail-shaped organ, and also the vestibular end organs. And so all of this is sitting here in this membranous labyrinth, and the membranous labyrinth is within the bony labyrinth, and it's separated by a layer of perilymph fluid. And then within this area, we have 3 semicircular canals. And so I'll just kind of point those out to you here. And we name those by their spatial orientation. So here they're designated as anterior, posterior, and horizontal. Sometimes the horizontal canal you'll see referred to as lateral canal. An anterior canal sometimes you'll see referred to as superior canal, so same thing. And in each of these canals we have this fluid, and that fluid is endolymph. And within each canal there is a thickened portion, and we call that the ampulla. And then there's a more narrow duct within the canal. And then these organs, which we call the otolith organs, that's where otoconia are, those are the utricle and the saccule, and they stimulate hair cells when the head moves. So the semicircular canals will detect turning of the head, and the otolith structures will detect things like linear acceleration, which includes gravity, and this will be important to note for later. Okay, so moving on, I just want to briefly mention the macula. So the macula, basically, it means small spot. And so you may be familiar with, of course, the macula in the retina, but there's also vestibular macula. And there's one that's in the utricle, and then again, there's one that's in the saccule. And in these tiny areas, that's where we see these patches of hair cells. And they are embedded in a membrane, and they're weighed down with otoliths, or otoconia. And so I'll just kind of point out, this is what's weighing them down here on this top layer. Okay. And so the otoconia themselves, they're basically calcium carbonate crystals, and they're in the macula like we just saw, and they're embedded in this matrix, this gelatinous matrix. And into that, the stereocilia of the hair cells will project into that substance. And, you know, patients, when you see them in the office, if they've had this treated or someone's told them about this condition, a lot of times they'll call these ear rocks, I've heard, or crystals. but the medical term we go by is otoconia, of course, and they're really tiny in humans. So the size range could be anything from 0.5 up to 30 micrometers, about 10 micrometers on average. And basically, they are very dense compared to the endolymph, and that's super important to realize because when we talk about the mechanisms behind BPPV, one of the theories is that these end up going into the endolymph fluid in the canals. And of course, part of the reason why we see nystagmus and why people have these symptoms is because you're introducing something that then is much more dense than the endolymph fluid that's within the canals. And so the otoconia will move in response to gravity. They'll move in response to accelerated movements. And they're so tiny that you cannot see these with the naked eye. Of course, you would have to use a microscope to be able to visualize them. So a little bit about some of the mechanisms now that we have an understanding of the anatomy. There are several theories, really, I would say, regarding what could cause or contribute to BPPV. And there are risk factors, things that have been independently associated with the likelihood of someone getting BPPV. But the prevailing explanation is that it is caused by otoliths that originate in the utricular macula that we looked at, and they dislodge, basically. And after they dislodge, they move within the lumen of one of those semicircular canals, and it could be any of the semicircular canals. It's all kind of an open system. And so they'll move into the lumen, and we've seen this in animal models and research studies, and it's actually even been seen in humans during ear surgeries, for example, during canal plugging surgery, which is rarely done to treat refractory BPPV, but these particles have been found within the canal. So we have some evidence for it. So we know that it's possible, but what's really causing the calcium carbonate to dislodge? Well, some of the reasons are not completely clear, but we have a lot of theories and evidence to support some of these explanations as well. So we know that BPPV can be post-traumatic. That is, it could happen after, for example, a concussion or a car accident. And it can be really hard to treat sometimes in such patients. So one explanation is that it can break off following trauma. It could also happen after damage to the labyrinth, and a lot of times that's from an infection. So, for example, something viral, such as vestibular neuritis or labyrinthitis, we see that this can develop in such patients as well. It can also happen in patients who have Meniere's, for example. It can also be idiopathic. Another thing that we have explored is that there are age-related changes in the protein and in the matrix of the otolithic membrane. And otoconia may cause this age-related change. And so there have been some studies kind of looking at what could happen to the otoconia with age and how they could degenerate and how they could play into BPPV. So let's take a little bit of a look at that. This is a study.
Could I ask you a question?
Mhm.
What is the difference between an otoconia and an otoconia?
Good question. It's all just comes down to terminology. So the otoconia, I would say, when you're talking about where the crystals are located in the utricle and or the saccula, you can just call them otoconia. We refer to them as otoliths when they're moving, meaning like they've been liberated. So when they're within the canal, that's a good question. Yeah. And so here's some pictures of some otoconia. And basically in this study, they compared different age groups of rats. And so they looked at rats that were young and some that were middle-aged and then some that were aged. And they looked at what their otoconia looked like. And so I'll just show you with this first picture here, these are in pretty good shape. And this is a middle-aged rat. And then the rest of these pictures are actually from rats that are aged. And so you can see all kinds of different forms of degeneration of the otoconia. So here's one that basically looks very fissured. You can see pits in some of these. Some of them have really just completely broken. And you can also get a sense of how they're all different sizes as well. And here's another good picture from the same study. And basically this one's showing some weak or broken linking filaments along with demineralization of the body of the otoconia. So you can see here that some of these filaments have just kind of broken off, and so they're not anchored well to each other anymore. And then you can also see how demineralized the body of the otoconia have become. So it can be plausible to think that then these degenerative otoconia could easily dislodge and wreak havoc when they enter the semicircular canals. All right, so just a little bit more about the mechanisms, and then we'll get into some more about the clinical management and the presentation of BPPV when we see our patients. But just to mention that we know otoconia are composed of multiple proteins and they interact with each other. They kind of form a complex. And otoconin 90 is the principal matrix protein, and it'll interact to generate formation of these crystals. And it forms a complex with Otolan 1, and Otolan 1 is the scaffolding protein. And these proteins have actually been used in studies to represent biomarkers when we're exploring BPPV a little bit more in detail. And so then you have the otolithic membrane, and it has this material that has, different glycoproteins. It has collagen in it. It helps hold it to the sensory epithelium. And as we discussed a little bit already, things like aging, things like trauma, viruses, all these things could result in the crystals breaking free, sinking into that endolymphatic fluid. Another thing worth mentioning is the association between BPPV and osteoporosis. And so studies have shown that BPPV patients are found to have more osteopenia and more osteoporosis when you compare them to matched controls. And those patients who are unlucky and get recurrent episodes of BPPV, they actually have tended to have the lowest bone density scores. This, of course, suggests that the spontaneous release of otoconia could be paralleling bone demineralization. And there have been studies that have kind of built upon this, looking at biomarkers, and they haven't shown strong correlations using the biomarkers. There have also even been studies looking at diagnosing BPPV in patients depending on what season of the year it is, and kind of correlating that with the thought that vitamin D deficiency could be involved, or vitamin D levels might be lower in winter months, and we see patients coming into ERs more often with BPPV during those months. All right, so we now know that it's possible for the otoconia to dislodge and they can travel into the canals. But how do they cause the features of BPPV that we see in our patients? Well, when the calcium carbonate crystals move within the semicircular canal, they cause movement of the endolymph, and that stimulates the ampulla of that affected canal where they are, and that's going to cause vertigo. And we'll take a deeper look at how that actually happens. And when they're freely moving within the semicircular canal, the term that we use is canalithiasis. There's an area within the canal called the cupula, and I'll show you another picture, but basically the particles can also adhere to that cupula, and that can be a bit of a challenge too. But most of the time they're free floating. We call it canalithiasis. And basically what happens is it changes the velocity of the endolymph because you have the increased addition of those otoliths. They're heavy. And this is going to result in nystagmus after a brief latency. So a brief period where we don't see anything. And this is going to follow a quick head movement that the patient will exhibit. And all of our head movements will induce the flow of endolymph. It'll stimulate the ampulla. What happens is it triggers the vestibular ocular reflex, but when we have that increased velocity, we see nystagmus. So this is a video taking a look at what I was just describing and the connections actually to the eye muscles that are involved.
Nystagmus, which is triggered by positioning with the Dix-Hallpike maneuver and other similar head position changes, is a hardwired circuit. It starts with displacement of the cupula by movement of fluid in the canal, then sends an excitatory signal to the brainstem medial vestibular nucleus. From here, the message is relayed to autonomic centers, sometimes resulting in nausea. The vestibular nucleus triggers the excitatory response to the contralateral trochlear and oculomotor nuclei, which cause slow tonic contraction of the ipsilateral superior oblique muscle and the contralateral inferior rectus muscle. This causes the eyes to drift down and intward. The rapid correction of this drift is the fast component of nystagmus.
Okay, great. also just wanted to point out that, even with all these studies, there have also been some looking at mathematical models to explain this, because again, this is somewhat of a theory, but the mathematical models have taken into account the size of the particles, and they have supported timing that would be consistent with what we see in humans, meaning, that latency that we see and that duration that we see of this vertigo when we're examining patients with BPPV, and to explain the characteristics of the nystagmus, so what that nystagmus actually looks like. And so we know that the magnitude of the nystagmus with the Dix-Hallpike maneuver is mainly going to be due to that total particle weight, so the particles that are within the canal. And we can also explain that the latency is related for the time it takes for the particles to move through the semicircular canal. And so when I say latency, when we test patients in that Dix-Hallpike position, we won't see the nystagmus appear right away. There's a latency of seconds usually. And so we need to wait before we see that nystagmus begin. So here's a diagram of what we were looking at just before in the video, of that area that can deflect within each canal, and that area is called the cupula. And so it's basically the motion sensor within the canal, and it's in the ampulla, and the ampulla again is that thickened portion within the canal. And it's this structure with a really mobile center. It can easily be deflected, and it gets deflected by moving endolymph, and then when the otoconia are added, it'll be deflected differently. And so what we see is nystagmus, and that's from the ampullary nerve being abnormally excited. And the direction is going to be determined by the nerve connection from the affected canal. So is that the posterior, anterior, or horizontal, to the extraocular muscles, like we saw in that diagram, and that's responsible for the direction of the nystagmus. So we talked a little bit about the canalolithiasis, which is the particles that are just, sinking, and they're free floating and they're causing hydrodynamic drag. And then the alternative is cupulolithiasis, and you can see then this shows them kind of heavier otoconia because they're acting as a weight on the cupula because they're kind of stuck there, and that can present a little bit more of a treatment challenge. Sometimes it can be more difficult to dislodge those particles when they're so stuck to the cupula, so it can take a little bit more work. But basically these particles are more dense, they move in the canal, they'll create fluid drag, they result in aberrant flow, it deflects the cupula, it modulates the activity of those vestibular afferents, so we saw that in the brainstem, it triggers the nystagmus. All right, so we have a good idea of what's going on. Now let's try and take a peek at what we see in patients and where this can actually occur. So we know it can occur in any of these three canals. Sometimes if patients are really unlucky, they have it in more than one canal. And people can even have it in more than one ear, so they can have it in the right and left ear at the same time. Sometimes doing the treatments can actually cause a canal switch, and so you could treat, for example, the posterior canal, and unfortunately, just by way of the treatment, you could send some particles into another canal, usually the horizontal canal. And then patients could still be having some symptoms, though they might be a little bit different because now they have particles in a different canal. So it underscores the importance of checking both ears, I would say, and being able to assess each canal, not just the posterior canal. Most often though, 85 to 90% of the time, or even sometimes higher, this is going to affect the posterior canal. And so we use the Dix-Hallpike maneuver to check that canal most thoroughly. So let's define BPPV a little bit. Stands for benign paroxysmal positional vertigo. Much easier to just say BPPV, of course. And the benign really implies that the vertigo is not due to central nervous system pathology and that the prognosis is generally favorable. However, I think it's worth mentioning that, it doesn't necessarily feel benign to people. It can also take a long time to be diagnosed or a long time to resolve. And so in that sense, it's not really benign. Also, patients are at risk for falls. They can be injured. They can really have limited day-to-day functions. And so in that sense, it's really not totally benign for people. It is paroxysmal though, in that the onset is very abrupt usually, and it'll come on in these brief episodes usually, and then calm down and then be triggered again in these brief episodes. And so the vertigo itself, it's this illusory sensation of motion, either of yourself or the surrounds. Often it's just like spinning that people will describe around them. But of course, there really is not truly that motion going on. In the posterior canal, typically going to be what we see. We use that Dix-Hallpike to assess for it. Smaller amounts of cases that you'll see will be from the other canals being involved. So if it's not the posterior canal, I would say move on to checking the lateral or horizontal canal, because 5 to 15% of the time that could be the canal involved. Especially if patients are still having symptoms after the posterior canal was treated, it could be that they developed that canal switch. And so it would be good to check that out. Very rarely will you see anterior canal BPPV. It's incredibly rare. And mainly you can provoke that by still doing a Dix-Hallpike. So even though we use the Dix-Hallpike mainly for the posterior canal, a lot of times you can actually see if the anterior canal is involved, and even the horizontal canal, though there is a better test for the horizontal canal that we'll talk about. It's rare to get it in the anterior canal because the anatomic position of that canal is such that it just makes it hard for the debris to enter that canal. And so, of course, the prevalence will vary based on what study you're looking at, but in general, overall prevalence during someone's lifetime is about 2.4%. And that prevalence is going to increase quite a bit, especially as we get older, so over the age of 60 typically. We usually see it in people in the 5th to 7th decade of life. If it happens due to trauma, patients can be any age, so you could see post-traumatic cases in much younger age groups. We always see it more commonly in women, and so that ratio is estimated to be anything from 2 to 1 up to even 3 to 1, and I would say anecdotally that's typically what I see is about 3 to 1 ratio women to men. And it's overall the most common vestibular disorder, so really good to have a great understanding of it. All right, so a little bit about the clinical history in the exam. So this is so important in really, of course, anything when we're talking to our patients and getting a neurologic history, but very important when you're talking about dizziness because it can be somewhat vague. And so you want to ask good questions and try to get the best description that you can get from patients. And most of the time you'll hear that they're having these abrupt spinning spells. And sometimes patients are a little off in their time estimation, but usually they'll tell you, you know, it was a minute or it was less than a minute each time that it's been happening. And a lot of patients will tell you that they noticed it, for example, when they were looking up. Sometimes my patients will say, you know, they were reaching for something. They were in the kitchen trying to get a bowl or something off a shelf. And so sometimes we call it top shelf vertigo. Or patients will say, you know, I laid down to go to bed and I rolled over, or it was when I got out of bed, or I rolled over to turn off my alarm clock, for example, and then got up out of bed and I got it. It can also happen when people bend over and then they straighten back up. So usually with those head position changes. Some patients are pretty good at telling you what side it happened. And that's just because, you know, they may remember, well, you know, I rolled over and I turned and put my head down to the right, and that's when it started. And so that can be helpful, but it's okay if they don't know because you're going to check both sides anyways when you examine them. So it's often suggested again by these brief spells of vertigo, getting out of bed. I would say that is the most common time I hear. So anything, you know, when patients are talking about getting in and out of bed, we start to think this could be what's going on. And when we do our exam, if especially we're looking for the posterior canal, then we are going to do that Dix-Hallpike maneuver. And that's a test that was named after actually two English neurotologists who first described it. And that's what's going to induce the nystagmus of posterior canal BPPV. And if we're looking for the horizontal canal, which we can test after we do the Dix-Hallpike, if we don't find anything, meaning we don't see any nystagmus on the Dix-Hallpike, but we still suspect BPPV, we could move on to what's called the supine roll test. And that is a test specifically looking at the horizontal canal. And we use these specific positions for the Dix-Hallpike test because it's going to allow us to evaluate particles on one side at a time, so 1 ear at a time, based on the plane of the canal in question. And again, it's worth mentioning that a lot of times you could see anterior canal BPPV when you do the Dix-Hallpike, and maybe when you do, when you're looking for horizontal canal as well. So you'll see this characteristic nystagmus, and the nystagmus is upbeat and it's torsional. And so it's really important to note that it's not just any nystagmus, it's going to be upbeat and it's going to be torsional, and it's going to depend on if it's the right ear or the left ear, which direction the torsional component will be. And it often fatigues and lessens with repeated maneuvers. So if you did a Dix-Hallpike and the patient became symptomatic and you saw the nystagmus and you sat them back up, if you were to repeat it again, check it again, you should see less of it, meaning it will fatigue if you do that maneuver again. And it should respond to repositioning. And so repositioning is the treatment that we use for BPPV. All right, so let's take a look at a couple of videos just showing us what we would expect to see. This one's right posterior canal BPPV. Okay, so we're seeing an upbeat nystagmus, and it's torsional. It has those two components, so I kind of think of it as moving in that type of direction. And if it's the right posterior canal, we see it move counterclockwise. And that latency is usually a few seconds, but I will say that it could be up to even something like 20 seconds. And so sometimes people don't wait long enough to really see the nystagmus. They might wait a few seconds and not see anything and think everything's okay, but it's really important to be patient and to wait with the patient in that position, because we know that this nystagmus can present after some latency. And then the nystagmus itself, kind of like we saw it here, it's usually going to last anywhere from about 10 to 30 seconds. It'll then start to kind of slowly taper off, slowly subside. And when it first starts, patients are very much going to report symptoms. So they'll usually say, oh no, it's starting, and they can feel it. And it's important to reassure them and help kind of keep them in this position so they aren't worried about falling, for example. And then once it starts to subside and kind of fatigue, patients will say, oh, okay, it's going away. Or you can ask them, are you starting to feel better? And they'll say, yeah, it's lessening, as you see that with their eyes in parallel. All right, so this one's left posterior canal BPPV. Let's take a look. All right, so again, upbeat and torsional is what we're looking for. And this one's clockwise because it's the left ear that's involved. Okay, so this video is going to show us an example of anterior canal BPPV.
This patient is taken from the sitting to head hanging left position. Notice she's developing nystagmus that is downbeating. This has a slight clockwise torsional rotation with it. And it's consistent with involvement of the anterior canal. Here's another patient who's been positioned from sitting to head hanging and has paroxysmal downbeating nystagmus.
All right, and so you can see that these patients were put in the Dix-Hallpike position. And so, yes, we're looking for posterior canal BPPV, but you could be surprised and you could see something like anterior canal BPPV as well. All right, so talking a little bit about the differential diagnosis, well, what else do we need to consider? In most cases, I would say it's pretty straightforward in terms of being able to determine whether it's BPPV versus these other conditions. So just a little bit of some things to remember in contrasting each of these. In postural hypotension, yes, people will feel dizzy based on positions, but BPPV is usually going to start, for example, when laying down, turning in bed, and you're not going to get that in postural hypotension. People aren't going to be reporting their symptoms usually when they lay down or when they're turning in bed. They also more commonly will report lightheadedness instead of the spinning that we so characteristically see with BPPV. Another thing that you might think of is acute vestibulopathy. So that could be from a vestibular neuritis or a labyrinthitis, for example. In labyrinthitis, hearing is affected, and of course in BPPV, hearing should not be affected, it should be normal. In an acute vestibulopathy, patients will continue to feel very dizzy for some time, and in BPPV, again, it's paroxysmal, so it's kind of coming and going, and they should have times where it's not so bad in between. So that's a good contrasting feature. And then in vestibular migraine, I would say that the BPPV symptom duration is usually shorter. So those paroxysms of vertigo are pretty quick, and oftentimes with vestibular migraine, patients are having vestibular symptoms that are longer. Of course, if you're getting a history of a migraine or that headache component, that can also be really easy to help differentiate, but we don't always get that history. And then central positional vertigo, that's something that we really need to be aware of and keep in mind when we're evaluating patients with BPPV, because when we put patients in these provocative positions to check for nystagmus, we can't just say they have BPPV based on any nystagmus. It has to be the nystagmus we expect to see in BPPV. There is something called central positional vertigo, which is very different, and it can cause central positional nystagmus. That will look different. It, of course, needs to be treated differently. Oftentimes, people need imaging very quickly and things like that. So really important to be able to differentiate it. And that could be caused by a number of central conditions. For example, MS lesions could present with a central positional vertigo, or cerebellar lesions from other pathology. In terms of differentiating it, there are a number of features that can help us to differentiate it. BPPV is typically not going to be a downbeat nystagmus. The exception being, of course, as we spoke about, if the anterior canal is involved. Whereas central positional vertigo, the nystagmus that we see with that, is oftentimes going to be localized to, for example, the vermis of the cerebellum, and that's going to be a downbeat nystagmus. However, it should come on usually without latency. So BPPV, you'll see a latency. Central positional nystagmus and vertigo, you should usually see it come on right away. It also doesn't usually fatigue, so it'll just kind of keep going, whereas the BPPV, vertigo, and nystagmus should fatigue. BPPV will also usually have that torsional component, whereas typically in the central positional vertigo and nystagmus, you're going to get more of a pure vertical component. So those are some tips for helping to differentiate between those. All right, and then I just wanted to take a moment to kind of go over some of the myths, because you see patients talking about different things, and they'll ask you all kinds of questions. Should they do this, or should they take this, or shouldn't they? So it's nice to be able to give them some appropriate advice. And so these are just a list of myths that I kind of came up with based on things that I hear and see often in my clinic. The first is, if a patient has vertigo with head movement, they have BPPV. Well, that's not really true. They could, but it's very vague. It's very nonspecific. And people with vertigo, they can feel dizzy with head movements, of course, and they can have a totally different condition. So they could have vestibular neuritis, for example, or vestibular migraine. So it doesn't necessarily just equate to BPPV. Patients need an MRI prior to diagnosing BPPV with certainty. This one is not true, which is really nice, because this is something that we can diagnose in our patients and treat without having to send them off to be imaged. A lot of times patients come into the emergency room and they'll complain of vertigo, and they'll have all kinds of tests done, labs and CTs, and then maybe even MRIs as well. And really, in a classic BPPV case, if you get your history and you examine them and you see that characteristic nystagmus, and then you go on to treat it with the repositioning and they get better, you actually don't need anything else. And so you definitely don't need an MRI for the classic cases of BPPV. Contrast that with, for example, you weren't able to treat it, or there was something strange about the nystagmus that made you suspect, could this be central nystagmus, or maybe they have some other focal findings on an exam. Of course, then you would be pursuing an MRI in those cases. All right, so next, patients need to do vestibular PT for BPPV. This is really not true. And that's because the repositioning, the treatment is so effective for BPPV. So very often, most patients just need you to do this, once, maybe twice. And most patients, they will be treated. They will feel better and their nystagmus will be gone. And so you don't need to send them off for a whole course of vestibular physical therapy. There are some exceptions if people are feeling quite unsteady. Maybe they've had the BPPV going on for weeks or months, unfortunately, and it hasn't been treated. Those patients tend to have more lingering symptoms. So they might have a little fear of falling or be feeling still, a little off or unsteady. So in those cases, it can't hurt. Sometimes on the rare occasion that you haven't cleared it completely, you might send them to work with a therapist to do some repositioning, but certainly they don't usually need a full course of vestibular PT. Okay, after canal repositioning, patients should follow postural restrictions so that BPPV does not return. This has been studied and it has not been shown to be effective. So, some patients will say they were told to wear a cervical collar, or they were told to sleep, sitting up for days. And that's just one, that would be difficult. And two, it doesn't show that it has, any impact on whether or not it's going to return or anything like that. So I generally do not give patients such restrictions after treatment. Patients with BPPV should use vestibular suppressants, such as antihistamines or benzodiazepines. This one's not true. I see this really commonly, and unfortunately, sometimes this is all patients get, depending on where they're seen. So sometimes, they have classic BPPV and they're, given a prescription for meclizine, for example, and that's it. And really, that's not going to do very much, unless they're just so symptomatic all the time. And maybe it dulls those symptoms a little bit, but usually you can just treat them. You don't need to give them these medicines unless, for example, they feel very sick with maneuvers, and so they could pre-treat with a dose before you do the maneuvers themselves, but you don't need to be prescribing courses of these medicines for patients. If a patient has nystagmus on the Dix-Hallpike test, then they have BPPV. Well, it depends on the nystagmus. So just have to be careful with that. If they have the characteristic upbeat torsional nystagmus that's either counterclockwise or clockwise, then we've isolated their issue to the posterior canal and it's BPPV. But for example, patients could be put into this Dix-Hallpike position and they could have central nystagmus. And that's, of course, not going to be from BPPV. BPPV usually resolves on its own, so treatment is not a must. I hear that sometimes. Well, in a lot of patients, it doesn't. It can take a long time, meaning weeks. It can even take months for some patients, and they're still having symptoms, and it has not gone away and has not been treated. So treatment's really important. It's such an easy, non-invasive thing to do that can help patients so much. So not treating is not a good idea. Repositioning maneuvers should be performed in order to prevent the return of BPPV. This one's not true, it's a myth. So repositioning maneuver is really important if it's active. If their BPPV is present, then you're going to do it. But you don't need to send patients home to keep doing repositioning maneuvers all the time once their BPPV has gone away. It's not going to help prevent the return of it. All right, so we spoke about the Dix-Hallpike, that's to test for BPPV. And then to treat is the Canalite repositioning maneuver, also known as the Epley. And these pictures are just showing it for the right posterior canal. And so basically, I'll just kind of walk you through it step by step here that are numbered. You're going to stand at the patient's right side, if you're testing that side, and you'll rotate the head 45 degrees as shown here. And that's just to align the posterior canal with the sagittal plane of the body. And then you'll move the patient with their eyes open from seated to supine with the neck extended about 20 degrees. The reason you tilt 20 degrees is so you can get those particles to move enough in the canal to trigger the nystagmus, and so that they move far enough into the canal, into the superior part, because you want to be able to have the treatment work for the patient. At this point, you want the patient's eyes open. Sometimes people might squeeze their eyes shut because they start to feel symptoms after that latency. So you want to try and have their eyelids open so that you can examine for 1, latency, 2, duration, 3, direction of the nystagmus. And you're going to maintain these positions for a while, longer than you might think. So 20 to 30 seconds actually. And this is very important. So you'll keep them in that position for 20 to 30 seconds. Things should have calmed down by then. You'll turn the head 90 degrees towards the other side, hold for 20 seconds, then turn another 90 degrees, another face down. Patient's body is going to need to move from supine to lateral decupitous position to help facilitate that. And you'll hold their head while they do that with their body. And then you'll hold their face down for 20 to 30 seconds, again at each step. And then you'll bring them upright to sitting. And as you bring them up to sitting, it's important to hold on to them. So you have a hand on their shoulder so that they don't feel dizzy or like they're going to fall with these steps. All right, so let's take a quick peek at what that looks like.
What's the nystagmus at this point? Then we proceed into treatment, or may have them sit back up.
And again, if you just move too slowly or you don't tilt the head enough, it could impair the test results because those particles aren't going to move enough to generate the force to defect the cupula and trigger the nystagmus. All right, here's the Canalite repositioning maneuver now, if we found evidence of the BPPV.
Does it matter which direction your patients are looking during?
The head is turned 45 degrees to the right side. Patient lies back. Examiner can observe from the nystagmus. That position is then held for 15 to 20 seconds. And the head is turned 90 degrees toward the unaffected side. And then the patient is manipulated so that the head is facing the floor. And that position is again held for about 20 seconds or so, after which time the patient sits up.
Did someone have a question?
Does it matter which position or which direction the patients are looking during these tests?
Yeah, that's a good question. No, so, sometimes they might look around a little bit, but generally once you bring them back into the position, I just tell people, just keep looking straight ahead and you're going to see the stimulation from that nerve excitation and it'll start to show the nystagmus if they're just looking straight ahead or even if they look a little bit off to the side. So no, that doesn't really matter. All right, so this is the maneuver, and it's just worth noting that the efficacy for this is honestly one of, just the highest things you'll see for something really. It's just so efficacious, and there have been a lot of randomized control trials that have shown this efficacy, and there's also a CMONT maneuver that's extremely effective as well. All right, so after the repositioning, symptoms might go away right away, and that's great. However, a lot of times if patients have gone untreated for some time, especially, they might just feel unsteady and they could feel, just off or foggy in their head or a little motion sensitive for days. And that can be normal if it's been present for a while, but you want to encourage them, return to your normal activities as soon as you can. And if symptoms persist, then you need to kind of think about a couple things. One, maybe it just wasn't effective or there's still some residual. And so you would just consider repeating the procedure. Another thing is checking the other canals and the other ear. Is the other ear involved now, or was it, and maybe we missed that the first time, or was there canal switch? So they're still having positional vertigo because, you treated the posterior canal, but now some particles went into that horizontal canal. And so you need to check that out. And then sometimes patients have just been, treating with a partner, for example, at home, which can be very effective too. That's been studied. But sometimes it can be difficult for patients to do it on their own. And so maybe if they were doing it on their own, invite them into the clinic because you may need to help them perform it. And then if they're still not better, then you want to start suspecting, maybe I should reevaluate this diagnosis, maybe I should look for other central causes, things like that. So you want to re-examine the patient.
On that point, how do you tell if both sides are affected or if more than one canal is involved?
Yeah, very good question. So I check both sides. And so, you could do a big Dix-Hallpike on one side and maybe you didn't do it the first time or something, but again, they're dizzy. So then you can check on the other side, but you can check both at the same time. And you could see evidence of, for example, posterior canal vertigo in each canal. If they're still feeling dizzy or something afterwards, I will check the horizontal canal. Also, if I got the history that this seems like positional vertigo and I did a Dix-Hallpike and I don't see anything, one, it's maybe they're subclinical, maybe they just got over it and the particles moved. But two, that could be in the horizontal canal. So then I move on to that supine roll test and I do that after the Dix-Hallpike, check each side there as well. And let's say you do find that it's present in multiple canals, that's going to be challenging. It is tricky, but you just start treating. And you may not be able to treat all of it in the same session because there's a lot going on. And so it may be difficult to kind of tease out what everything's looking like, but you pick something and you treat it. So you treat posterior canal maybe that day and you see how things go. And then you follow up with people in a shorter interval and you check and you see what has maybe gone away or subsided and what is still present. But it can be definitely more challenging if multiple canals are involved, and it is very well known that they're going to need more treatments and more follow-up in those instances.
Which side do you test first? If you're going to test both sides of the Dix-Hallpike, if, for example, you see rotatory upbeating nystagmus in the clockwise direction, you think it's left, if I'm remembering that correctly,
Yep.
Would you test the right ear first or the left ear first?
So what I do is sometimes I'll ask patients, like, when I'm getting that history, when did you start to notice it? And they might say, oh, it's my right side. I know it is, and so that's giving me a good clue. Now, some people, when they hear something like that, just depends on, I think, the physician's preference, but they might think, well, I'm going to check both. So I'll check the opposite side first because I'm not suspecting it there, but I'll look there because I don't want to make them sick. So that's one school of thought. If the patient, most of the time, though, it's just going to be in one ear. I mean, that is the typical situation. And so, in my patients that I know, if they tell me, it's my right ear, I know that I'm generally going to check that side first because they've told me that they've had the symptoms, or I've seen them before and that's where they had it last time. If you look at studies, most patients actually have it on the right side compared to the left, but of course, anything's possible. So here's a video of the lateral canal BPPV.
This patient has just been positioned from the sitting to the head hanging position on the right side. In essence, a right-sided Dix-Hallpike maneuver. Notice the nystagmus is predominantly horizontal rather than upbeating. This is typical of horizontal canal BPV. Now, in a moment, you'll see her position her head from the straight to the head left position. And now notice the nystagmus that develops has changed direction from right beating to very prominent left beating. Again, this is characteristic of horizontal canal benign positional vertigo.
Okay, and so I would just say, it's important to note in this canal, the nystagmus is often a higher velocity than what we see in posterior canal. And the duration is usually going to be longer, so it can be up to a minute before it's going to subside. All right, so here's that supine roll test that I talked about doing, after the Dix-Hallpike if I haven't found my answer, or if the symptoms seem that they're going to be localized to that canal based on what they're telling you. And so what you do is you just kind of tilt their head forward at 30 degrees, flex at the neck, and you'll turn their head to the right side, check for the nystagmus like we just saw. Then bring back to face up position. After it subsides, turn the head the other way and check for nystagmus. And so you can see it with Dix Hallpike, but this supine roll is more specifically going to move particles in the horizontal canal. And so you'll see a larger change in force of the otoconia with this. And what do we see? Well, this one's a little bit more detailed. So basically, you'll either see what's called geotropic or ageotropic horizontal nystagmus. Geotropic meaning towards the floor, down. Ageotropic, obviously the opposite way, so away from the floor or up. And it's really important to notice which way it's going, because that's what's going to help you figure out which ear is the culprit. And that can be a little bit challenging. Sometimes it's easier, sometimes it's not so easy. If it comes after an epley, so maybe you suspect a canal switch or something like that, you can pretty safely assume that it's going to be that same side, so the same ear that you just treated for posterior canal. But if not, and you notice, okay, it's beating towards the ground, it's geotropic, the side with the stronger nystagmus, like we saw in that video, we saw one side was much more stronger than the other, that's going to be the involved ear. Whereas the opposite is true if you see it beating up. So if it's ageotropic, it follows the opposite rule. So the side where it was weaker, that's going to be your involved ear. And then that'll help you figure out where to start when you do the treatment. And let's say you can't figure out, just pick a side and at least try treating, because you're going to reassess, you're going to reevaluate afterwards. And the treatment, there are a couple that have been studied. And one that's pretty common that most people, I would say, use is the barbecue roll or the Lempert 360 degrees roll maneuver. And this one literally is just rolling. So this picture is showing treating right lateral canal, the geotropic type. And so basically, you know, people start flat and they're showing the head turned to the right. You would see them have symptoms because it's the right side that we're talking about in this diagram. And then what you do is you start rolling to the unaffected side. So you can see here, you turn the head to the other way. So now it's to the left. Then you have them turn their body and they get to where they're kind of on their elbows and forearms and their head is down. Then they turn again and they're facing the opposite side. And then you help bring them back up so that they're sitting up. At each position, you're going to hold for 20 to 30 seconds. So here's a quick video.
Lempert maneuver for right horizontal canal, benign position vertigo is performed by having the head turn in sequence of maneuvers 90 degrees to the unaffected side. In this case, the right side is affected, so the head is turned toward the left. That position is held for 10 to 30 seconds, depending on the duration of the nystagmus. The head is then turned to the face down position, held again in that position for 15 to 20 seconds. Another turn, now back toward the right side. And then from here, the patient turns to the straight supine face up position and then sits up simultaneously.
Okay, so I think, you know, that's clearly a demonstration. I've never seen someone look that happy if they really had this vertigo going on when you're doing those maneuvers, but hopefully you get the idea. So, and then just a little bit about the evidence. So there is a clinical practice guideline available that has been updated, and basically it was developed by the American Academy of Neurology, head and neck surgery, and it was affirmed by the AAN in 2017, and it's quite detailed. It gives various level recommendations for or against things. So I couldn't put everything in here, but just a couple of the strong recommendations as take-home points. One is just about the diagnosis. So you diagnose the posterior canal BPPV when you have that vertigo, the characteristic vertigo provoked by the Dix Hallpike, done by this maneuver. And then another one is about treatment. So clinicians should treat the posterior canal BPPV with Canalite repositioning procedure. So this is the treatment for it. If you can't do it, send them to someone who can. And then clinicians should not recommend post-procedural postural restrictions after Canalite repositioning. And we talked a little bit about that. So stuff like sleeping upright or wearing a collar, things like that. All right, and I'm going to wrap up here, but I just wanted to briefly mention also that this can be quite a burden on patients if it goes on untreated. And it's of course a burden on the healthcare system because it can be very costly. And a lot of the cost comes from not being properly diagnosed. So maybe patients are seeing a lot of different doctors, or they haven't seen someone who can treat it accurately, or they're presenting places and getting a whole slew of tests done for other types of vertigo or dizziness, for example. And so that can account for a lot of the cost. And really, if you see that characteristic exam and you treat it and people feel better, that's all you need. That's one of the beautiful things about this diagnosis and treatment, is that you can have them come into the office and just fix them, and patients will just be so grateful and amazed often by how easy the treatment was and how much better they feel. And I think another thing to consider is that you have different specialties that are seeing these patients. So some may be doing things differently. They're seeing, being seen in the ER, and it may be more difficult to do the positioning, or people don't know how to do it, and so they're giving medications instead, things like that. So unfortunately, there's a lot of variation in what patients may deal with or face. And lastly, I think reminding ourselves that this is very common as people age, the prevalence goes up. So it's good to have a low threshold, in patients who are elderly and dizzy, to check for this and see if it's something that could be going on for a while, because you can fix it easily and then you can prevent them from falling. They can get back out there and do their own ADLs. They're not so dependent on people, and they can live their life. And so you can really help people with just a few easy steps to these maneuvers. And hopefully you learned something from going over this with me today. So thanks again for this opportunity to talk. And if anyone has any other last minute questions, I'd be happy to take them.
Thanks for the talk. It was great. I have a few questions, if you don't mind. With anterior canal BPPV, you get the same torsional component. Does it have the same implication that clockwise is one direction and counterclockwise is the other? And is it the same for both posterior and anterior?
No, yeah, it's the same exact thing. Yeah.
And if you saw someone with acute onset downbeat and nystagmus with a torsional component, would you be more apt to get imaging because of the rarity of the anterior canal involvement?
So I would try treating it.
Okay.
And if it didn't change, and if the patient didn't feel better that day, for example, and maybe they go home and you check in with them or something, if they don't feel better that day, then yeah, I would consider imaging.
Cool. Yeah, as someone who's experienced this once in my life, I can attest it is not that benign. It is just unpleasant. And it is amazing how easy the treatment is.
Agree, yeah. All right, well, thank you so much.
Okay, is that the end, Dr. Saha?
Yeah.
Okay, awesome. Thank you so much for having this with us, and Dr. Weber for being our Q&A moderator again. Thank you everyone else for joining the 6th AN Virtual Resident Education Lecture Series. These are recorded and will be available through AAN.com and AAN YouTube. The next series is October 28th on pediatric headache. So look for the Zoom links on AAN social media channels. Otherwise, thank you for joining us, and everyone have a great rest of your day.